Good morning. It's Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. Today we have number 4 in the Neuro IMC sessions run by Luis Lopez Ibor, neurointervention radiologist from Madrid. And I'll turn it over to the host, Warlix. Welcome, Warlix.
Hi, greeting from the 4 Neuro-IMC sessions, the global online communities of neurointervention radiologists. So today we are really present to give you the presentations today. Dr. Luis Lopez is our course director. I am Warlix. I'm your moderators today, as well as Dr. John Bennett. He's the co-host. Today we have interesting topics about median cerebral artery aneurysms, microsurgery versus endovascular treatment. We have 5 speakers who are specialties in different fields. So we will begin. Okay, let's move on to Dr. Bin. He is also the neurovascular and bypass surgeons from China. He's from Fudan Hospitals. So Dr. Bin will give his talk about the surgical management in the middle cerebral arteries aneurysm part 2. Okay, so thank you, Dr. Bin.
Okay, thank you, Warlix. So today my topic is bypass for complex MCA aneurysms. So I come from Shanghai Huashan Hospital. So for the MCA aneurysm, mostly we still use open surgery as a best choice because like this simple, very simple MCA aneurysm, the clip can get very good surgical result and almost don't worry about the recurrence. And sometimes if the MCA, especially the segment of M1 to M2, there's some fetal perforators. So normally we should save the perforators. And like this patient, I use 11 clips to reconstruct the floor cavity. So like this patient, I use the vessel, the aneurysm have involved around 300 degrees of the vessel wall. So I use one backside, one frontal side to reconstruct the vessel cavity. But for the giant and the complicated aneurysms, we still need the bypass, especially for the MCA M1 to M2 segment aneurysms. So this is like this patient. Now fluid diverter also it's a choice, but still have high risk of bleeding comparison to the clipping. Like this patient is a 10 years old young boy, big M1 aneurysm. Actually, it's feasible to put a fluid diverter in it, and they use a pipeline, combined coils. It looks quite good. Everything looks good, but in the afternoon, it got the hemorrhage, and they did the decompressive craniotomy. And this is the final result. Although the final result is quite good, you can see the vessel wall was reconstructed along the fluid diverter, but the patient already have some complications. So bypass treatment is a hemodynamic treatment of MCA aneurysms, normally combined with some other procedures like bypass combined proximal direct occlusion of MCA. If the vessel wall was quite thick, and we can consider the distal occlusion of MCA. And the MCA also can combine with trapping of the MCA aneurysms. So the purpose is to decrease the pressure of aneurysm wall, keep the blood flow in perforators. This is very important, and keep the blood flow of distal parent artery. And the protective, sometimes we also use the protective bypass, which use this technique, we can get more time for clipping the aneurysm. So MEPSCP was monitored as a routine in every complex MCA aneurysm. So this is a ICG flow 800 is helpful in selecting the recipient artery. So normally, if you have a hybrid operating room, that's the best choice. You can see this patient, it's MCA giant aneurysm, and we did the distal bypass of the STA MCA. You can see the blood flow reflux to the aneurysm wall, but the aneurysm didn't show the large part of the aneurysm wall. So then we combined with the distal clipping of the aneurysm. Actually, the final result was quite good. So for the MCA aneurysm strategies, if it's a fusiform MCA aneurysm, we use non-dissecting fusiform aneurysms. So if the LSA was involved, we will use partial clip trapping, combined high flow ECIC bypass. If the ALSA was not involved, we will use clip directly reconstructing and sometimes clipping, wrapping. I think wrapping is very important if the 300 degrees of the vessel wall was involved by the aneurysm. So we can use fenestrated clips. I call it like outside of the vessel's stenting. So if you use 2 or 3, this outside fenestrated clip, actually the vessel wall couldn't be expanded anymore. So it's a fusiform dissecting aneurysm with thoracoectotic dissecting aneurysm, or sometimes giant serpentine aneurysms. We will use some blood flow measurement before the surgery. We have the NOVA system, and if the patient only involved the perforators and some MCA territory of the MCA distal territory. So this kind of patient, we use partial trapping combined high flow ECIC bypass. If involved all the bifurcations, if involved the 3 trunks, we can use proximal occlusion with combined bypass. If it involved 2 trunks, we can use proximal occlusion combined high flow ECIC bypass or double STA M2 bypass. So this kind of patient only used in the male patient. The STA was quite larger than 1.2 millimeters. If it's only involved 1 trunk, we can use a partial trapping combined with a low flow, normally STA MCA bypass. If it's a post bifurcation, normally the STA MCA bypass was enough to replace the involved trunk territory. So my personal principles is surgical plan should be as simple as possible, bypass time as fast as possible, and the number of the stomas as few as possible. I have some technique notes. Replace enough blood flow for MCA territory or partial replacement. For the male patient, normally 2 STA branches are enough to replace the whole MCA territory. The female patient, normally the STA was quite small. If it's smaller than 1.8 millimeter in the diameter, so we should combine with the radial artery graft. So if the 1 STA branch can create, sometimes we can use 1 STA branch to create double bypass to increase the donor flow. So this is a male patient. You can see normally the 2 MCA branches are enough to replace the MCA, the whole MCA territory. you can see the double bypass was all patent and the blood flow come to M2 segment and replace the whole MCA territory. Sometimes we can use the single branch of STA to create the double barrel bypass, one in the superior trunk, one in inferior trunk. So before the surgery, we can check the blood flow, the territories of the superior and inferior trunk. So this is type 1 distal ICA to M1 segment. So this kind of patient, we should replace the whole MCA territory and the protection of the perforators. You can see the balloon occlusion test was strongly positive. So use under the MEPSCP monitoring, we can trapping the aneurysm very accurately, and this is MEP STA to radial artery to MCA bypass combined with the trapping of the aneurysm. So we saved all the perforators. So this is the final position of the clips. So this is another case. You can see this is a very giant MCA aneurysm. So this is a female patient. So we use STA radial artery from the ECA branch to radial artery to MCA territory, combined with proximal occlusion of the aneurysm. Actually, clip of the parent artery to the proximal distal, proximal end. So this is the second type, unruptured M1 aneurysm with thick wall. So this kind of patient, we can consider the distal occlusion combined the distal bypass. So the blood flow replacement should cover the 2M2 segment. So this is after this double bypass, we can see the double bypass was all patent and one in the superior trunk, one in inferior trunk of MCA. And we clipped distally of the aneurysm. Just after 1 week, we can see the CTA, the aneurysm was closed and didn't show anymore. So even distal MCA superior trunk aneurysm, this is even easier. So we can only replace the superior trunk territories. So this is actually, I finally clipped the vessel cavity perfectly. You can see in this, after the surgery, you can see the vessel cavity was all good, but it needs time to get this result. So before the treatment of the direct clipping, I made the distal STA to M4 or M5 bypass. So this can give us more time to reconstruct the vessel cavities. So this is even distal one. You can see this is a superior trunk. Actually, if the patient's vessel was long enough to do the direct bypass from proximal to distal, so I removed the aneurysm and did the end-to-end aneurysms directly. And this is the final result. You can see the vessel wall was reconstructed very well, and there's no aneurysms. So this is even distal involved only small trunk of superior trunk of MCA. So I only use the STA, one chunk of the STA to do the STA to distal MCA bypass, and then we check the vessel patency in the operating room, and we can see the vessel wall. The anastomosis was a very good patent and replaced the distal territory of the superior trunk, and then we directly clipped the proximal end of the aneurysm. So this is even distal. You can see this is in the almost in the cervix fissure, and you can see it's quite a large aneurysm. So the vessel wall was so thick, so I don't worry about the rupture of the aneurysm. So I only did the distal clip, combined distal STA-M3 bypass. So you can see the distal clip of the aneurysm combined with distal STA-MCA bypass. So this is another type, hybrid treatment. This is a you can see I use this is involved the LSA on the vessel cavity. So this is quite critical to treat the bypass and occlude the proximal end of the STA, MCA. So I use direct STA MCA double bypass. Then I close the aneurysm through the MCA M1. You can see after the embolization, the small perforators was all patent in this area. So this patient have no complications. So this is a hybrid treatment of the complex aneurysm. So I also treat, I also test some new graft, like this patient. This is a right GEA. This patient is quite short, and his radial artery was too short to do the direct bypass from MCA to ECA to MCA. So we tried this new graft, and it's quite long. The right GEA can longer than 25 centimeter. So that's enough to do the direct bypass. So this is after the bypass, you can see we just follow up this patient. The bypass was patent, and the aneurysm didn't show anymore. So this is a post-operative CT. And this is just after the, in 1 week after the surgery, you can see distal occlusion of the aneurysm, and the aneurysm only has a very small endpoint of the M1 segment. So now we already followed up after 6 months. It's quite good, and the aneurysm disappeared. So this is a take-home message. Every MCA complex aneurysm should have a tailored plan for blood flow replacement and the protecting of important perforators. The surgical plan should be as simple as possible. The bypass time should be as fast as possible. Number of the stomas should be as few as possible. One branch of the STA can create double barrel bypass to increase the donor artery. And the radial artery and the right GEA can be used if STA flow was not enough. The distal occlusion of parent artery only used in unruptured thick wall aneurysm with important perforators. And the MEPSEP monitoring is important. And the intraoperative ICG or angiogram is here before. Okay, thank you.
Thank you very much, Dr. Bin. It's very amazing. Okay, so I think if Dr. Juha is ready, you can be next. Professor?
Could I ask a question?
Oh, yeah, sure. Okay, sorry. Yeah.
Can you hear me?
Yes.
Yes, yes.
So no, I was thank you very much, because this was a very impressive presentation, and I have a small technical question concerning the wrapping of the aneurysm. The aneurysms that you said you do that with the fenestrated clips, huh? Like a series of fenestrated clips.
Yes.
Do you put like muscle or gauze or stuff also beside the clip placing, so to reinforce the wall, or how do you do it exactly?
Oh yes, depends on the length of the vessel wall. So if it's quite short, we can directly reconstruct it with the fenestrated clips. But if it's quite long, we can use some dichrome material
Exactly.
to support the vessel wall.
Yeah.
Okay. Is there any questions from the panelists? You can leave the questions on the chat or in the Q&A box.
Professor Bean, one question. When you finish the anastomosis, you are, how many cases you are restenosis in local stenosis after anastomosis in this type of aneurysm?
You mean in situ direct bypass, direct anastomosis?
Yes.
Only one case. Only one case.
And you treat it with Neurosurgery, or you treat it by balloon angioplasty?
No. I resected the aneurysm wall totally, directly, and the distal and the proximal end was long enough to do the direct anastomosis.
Okay.
Yeah. Sometimes if it's not long enough, you can graft one segment of STA. It's another treatment. Yeah.
And you see in your experience, you are the case, you are collateral circulation in lenticulostriate artery. Sometimes there are some loop. Is frequently this?
Yes, this is a most important consideration before the surgery. When we make some surgical plan to protect all the perforators of the M1 segment.
Oh, thank you.
Thank you. Maybe if there's time, I have also one short question for Professor Binshu concerning the distal aneurysms, like in M3, showed a couple of cases. Would you do in those patients maybe like a balloon test occlusion to see, because sometimes there might be collateral circulation and just occlusion of that branch would be feasible? Is that something you do as a routine, or you have special?
No, actually before the clipping, we sometimes clip the proximal part of the aneurysm and do the ICG to measure the blood flow and the velocity of the blood flow. And if the blood flow came back through from the collateral, and the MEP SEP was quite normal, you can just clip the proximal end of the aneurysm. Yeah, that's same as the balloon occlusion test.
Yeah.